Hello, I'm Steve Pearson. We'll be starting our public meeting in about 1 minute. So please hold on. Thanks for joining us.
Good morning, everyone. My name is Ralph Brindis. I'll be serving as the chair of the CTAF meeting today, where we'll be discussing the therapy of ICER for metachromatic leukodystrophy, its effectiveness and value. So it's my pleasure to now open the meeting and call it to order. And at this time, I'd like to call on each individual CTAF member to introduce themselves, to declare any potential conflict of interest, and also to briefly describe their work. At the beginning of any CTAF meeting, we want to ensure that all speakers disclose any financial relationships with industry. Every member of our CTAF panel who is present today has met the ICER conflict of interest policy. So again, would each CTAF member introduce themselves, the work, and note whether they have any updates to this declaration? I first would like to call on Dr. Hawks.
Good morning, everyone. My name is Jeffrey Hotch. I'm a professor and chief of the Division of Health Policy and Management in the Department of Public Health Sciences at the University of California at Davis. I'm also the Associate Director for the Center for Healthcare Policy and Research. I have no conflicts of interest.
Thank you, Jeffrey. Dr. Jeff Klingman.
I'm Jeff Klingman. I'm an adult clinical neurologist at Kaiser Permanente in Northern California. Excuse me. And I have no conflicts and no updates.
All right, thanks, Jeff. Mr. Robert Collier.
Hi, I'm Bob Collier, 30-year, more or less, professional patient advocate nowadays across the world of medical research. I have no conflicts of interest.
Dr. Rita Redberg.
Hi, I'm Rita Redberg. I'm an adult cardiologist on the faculty at UCSF for the last 30-something years, and I have no conflicts and no updates.
Thanks, Rita. Dr. Sei Lee.
Hello, I'm a geriatrician and a professor of medicine at UCSF, and I have no updates to my conflicts.
Thank you. Dr. Rena Fox.
Hi, I'm Rena Fox. I'm a professor of medicine at UCSF in the Division of General Internal Medicine, and I have no conflicts of interest.
Mr. Stephen Kogut.
Hello, everybody. I'm Steve Kogut. I'm a professor at the College of Pharmacy at the University of Rhode Island, specializing in managed care pharmacy and medication outcomes research.
Dr. Greg Lowe. Do you have any new conflicts to disclose?
Sorry, I forgot to add my conflicts. I don't have any updates to my conflicts of interest. Thank you.
Thank you. Dr. Mr. Donald Crease.
Good morning, everybody. I'm Don Crease from Concord, New Hampshire. I'm a lawyer and utility ratepayer advocate by day, but I'm here as a patient family advocate by virtue of being a cystic fibrosis parent, and I have no conflicts of interest to disclose.
Thank you. Dr. Greg Lowe.
Hi, I'm Greg Lowe. I'm a pharmacist and pharmacoepidemiologist at Massachusetts General Hospital, where I'm the director of the Physicians Organization's ambulatory pharmacy programs, and I have no conflicts or disclosures.
Dr. Aaron Mitchell.
I'm a medical oncologist at Memorial Sloan Kettering Cancer Center. I have no conflicts of interest.
Dr. Jason Wassey.
Hi, I'm Jason Waspy. I'm an associate professor of medicine at Harvard Medical School, and I'm a cardiologist at the Mass General Hospital, where I direct our research program in health services research. I'm also chair of New England CPAC and here as a guest today, and delighted to join for this really important topic.
Thank you. Ms. Rebecca Kirsch.
Hi, I'm Rebecca Kirch, based in Washington, D.C. I do health policy with the National Patient Advocate Foundation. I'm also a family caregiver, and I have no conflicts or updates.
And again, I'm Ralph Brindis. I'm a clinical professor at UCSF, a cardiologist by training, involved in outcomes research, and I have no new disclosures to call on. At this time, I'd also like to introduce our individual patient and clinical experts and have them introduce themselves and declare any potential conflicts of interest. Our first is Marla Kafalis.
My name is Maria Kafalis.
I'm sorry.
No, it's all right. You got the easy, hard part right. My last name. I am the founder of Cure MLD and the Calliope Joy Foundation. I'm a patient advocate in the MLD space. My daughter, Calliope, had MLD and passed away in March of 2022.
So sorry. Taryn Sir.
Hi, I'm Taryn Sir. I'm co-founder and executive director of the MLD Foundation. I'm mom to 2 children with the late juvenile form of MLD. I'm a active pediatric and ICN RN, and I helped develop the newborn screen for MLD.
Thank you for being here. Dr. Francesca Fumagalli.
Good morning. I'm a neurologist at the Sir Raffaele Teleton Institute in Milan, the center where Arsacel has been developed, and I'm an investigator of clinical trial conducted and supported by Orchard Therapeutics. Such as investigator, I'm this conflict of interest of being part of the clinical trial that were presented today.
Thank you. Dr. Paul Orchard.
Hello, I'm Paul Orchard. I'm a pediatric blood and marrow transplant physician at the University of Minnesota. My practice is primarily in the use of cell and gene therapy for patients with rare life-threatening disorders. So, and just to be clear about this, so the sponsor of this gene therapy is Orchard Therapeutics. It is not my company. And we have worked with Orchard Therapeutics in developing compassionate use therapy for a limited number of patients here.
Thank you. It's my pleasure to introduce Dr. Steve Pearson, the president of ICER, who will take it from here. You're on, Steve.
Thank you very much, Ralph, and welcome to the members of the California Technology Assessment Forum who will be with us today, and to our patient experts and clinical experts. At the beginning of every ICER meeting, we like to kind of ground ourselves in, why we're here today. What's the purpose of this meeting? What's the overall enterprise about? Why are we coming together? And we want to start that with a foundation in the patient and family's experience. So here's a quote from the parent of a child with MLD. Our son's condition has impacted him immensely, as he was once a healthy, active child who would always be outside with our dogs or riding his bike. Now he's non-mobile, non-verbal, unable to swallow safely. So he's tube fed. He has no voluntary movements of his limbs, and he's starting to lose his sight. He does have a little head control, but only for a few seconds before his head drops forward. Now we'll hear throughout the day from patients, from family members, around the devastating impact of this condition on individuals and their families. And that really is the core thing that we want to kind of take on board, is the tremendous unmet need, if you will, the tremendous impact of this condition on families. So when a new treatment for a condition like this is approved by the FDA, what happens is a remarkable sense of celebration. There's a sense that after years of commitment from the patient community in trying to help with clinical trials, of participating in them, after years of investment, risk-taking by companies, by clinical researchers, that we have a new treatment that we can offer that will really make a difference, hopefully, in people's lives. Also, on that day that the FDA approves a treatment, usually there on that day or thereabouts, companies will announce a price, and they will probably already have been in discussion with major insurers in the weeks and months leading up to that around how it will be covered by insurance. And there are lots of ancillary questions that come up around those decisions. First, what are the risks and benefits not just seen in the trial, but maybe if it's going to be used now in a broader set of patients, what do we really know about where it works best, for whom it works best, where are we still having a lot of uncertainty? For some treatments in particular, we have bigger questions than perhaps here about how the treatment fits into the treatment landscape. Are there other treatments that should be tried first and then this one? How do we kind of place it in the right role and sequencing of therapy? As I mentioned, with the prices that are announced at the time of approval, there are questions about what is a reasonable price. Is there competition at all? If not, who's deciding what the price is and what a fair price would be? And what ultimately happens to individual patients, their families, and others in the healthcare system around these questions about the costs to, again, not just individuals, but health systems and even governments. And we always want to ask, what lessons can we learn, have we learned, but can we learn going forward about how to get this right for future innovation and right for the here and now, and what can we learn and how do we get it into the healthcare system? So one of the other reasons we're here today, and I made kind of reference to this, is we're thinking a lot about the patient and their family, but we also have to keep our eye on the impact on other people. And to a certain extent, that means what effects happen when we have rising healthcare costs overall. And I'm just going to show, the picture of several families and individuals who are in the public domain with their stories of how they were affected by rising healthcare costs. And this isn't just the out-of-pocket that they have to pay through their insurance. It is partly whether they can afford insurance at all, the healthcare premiums that are charged as insurance costs become more expensive over time. Just briefly, the family on the left, the Ward family, they had the premature birth of the twins that you see here and started to accrue out-of-pocket costs that led them into near bankruptcy, and they had to move, change jobs so they could live with family members, and it completely kind of upset, if you will, their family planning around their future. And that was mainly due to how much they had to pay out of pocket that was beyond their insurance terms. But their insurer had made limited insurance available because the overall cost of more comprehensive benefits was viewed as too expensive. The couple in the middle, the Buck couple, they are from Arizona. And kind of ironically, his job was to get on the phone with people and help them get signed up for Medicare Advantage. It helped them get better insurance when he himself did not have good insurance, did not feel like he could afford it, ended up in the emergency room, and rapidly thereafter, they did end up in medical bankruptcy, which is one of the leading causes of bankruptcy in this country. And the survey actually, that was the focus out of which these individual stories arise, and the links there at the bottom, the survey suggested that up to 100 million Americans are carrying medical debt on their credit cards or are in receivership, and people are out trying to find them to get the money back. And that these people have tremendous mental, physical, and other burdens. Some of them are getting turned away from doctors' offices and ERs because they don't have insurance or they're known as having medical debt. And so this is a crisis, if you will, that afflicts a lot of people who are rarely in the room when we talk about new treatments and all the wonderful things that they can do. And it's important to have some kind of broader ethical framework within which we see this. The last person on the left, she also had to declare bankruptcy. She was on a plan that capped her payment after she left her employer. And sure enough, she blew through that with her healthcare needs. And so there are a variety of reasons that people end up being hurt by rising healthcare costs. There are a variety of ways, but it's just part of the broader context of why we're here today. Because as I said, we are going to keep our focus on the center being individuals and their families who can benefit from a new treatment. And we want to talk about the evidence and where some of those boundaries might be, but we want to really recognize against and celebrate the opportunity to do well by people who have a very serious medical condition. But absolutely, we live in a world in which, whether we recognize it or not, we are part of a network of other families, other people, whether they're in our insurance company or just more broadly in our society. And we have to come up with a way that is sustainable and affordable for everybody to be able to have adequate healthcare insurance and adequate healthcare. So we're here to try to place our concern and focus and hopes for the people in the center of this picture with the balance that we need to take both today and going forward. So you've had the ability to meet the members of the California Technology Assessment Forum, and I just need to say a few words about ICER, which is the convening host for today. First of all, in terms of our funding and potential conflicts of interest, we keep an updated pie chart of our revenue sources on our website. And as of where we are in 2023, as you can see, we get almost exactly 2/3 of our funding from nonprofit foundations that are not affiliated with healthcare industry. The primary funder there is the Laura and John Arnold Foundation. We also receive funding from the California Healthcare Foundation, from the Robert Wood Johnson Foundation, the Commonwealth Foundation, and others. We have about 22% now of funding that comes in directly from life science companies and from health plans and provider groups, but that is kept separate in an ability to fund our program with them that we call our Policy Summit program. And that is to convene them and to try to work out policy solutions to some of the tensions in our healthcare system so that we can get better evidence and definitely better access at sustainable pricing. And about 11% comes from a mix of subscription to our ICER Analytics cloud-based platform of our work that can be tailored for individual purposes, and direct philanthropy from individuals. The report today that's the kind of backdrop and foundation for the discussion was developed over about 8 months, and it's a very intensive process, as you can imagine. And it starts, though, with our reaching out and talking to patients and their families. We may not know very much about the condition and the treatment. We may know a lot about it, but we need to start by making sure that we step back and say, we need to learn. We need to learn what the lived experience is, what the diversity of that experience is directly from patients and their caregivers. We obviously also talk to clinical experts, the manufacturers, and others to try to make sure that we're getting as broad a perspective on these issues as possible. So once we've kind of got our North Star and our kind of orientation set, then we do a deep dive into the evidence as we can find it. That's usually looking at certainly at published evidence, but we work a lot to see if there's evidence that might not be published yet that we can work with. We work with patient groups sometimes to see if we can get direct evidence from patients in some way that can feed into a broader view of value. So our work on these reports goes through several different draft versions that gets comment both publicly and from our key stakeholders. And for this report, as it neared the tail end, we did get expert review from Dr. Fumagalli, from Dr. Orchard, from Ms. Sir, whom you heard from earlier also, and from her husband, I see, and from Paul Tappenden, who is a professor of health economics. So they help complement, certainly, and give a very kind of detailed review of some of the earlier draft versions. Now, in that report, there's a structure that is itself meant to convey how we want to think and talk about value. Because at the end of the day, we're going to be talking a fair amount around how the price does or does not or will not align with what we think of as the value to the system and to patients. And so how we look at that is kind of a composite look. Value is a many-splendored thing. And so we want to think about what are the variety of ways in which a new treatment can provide value. Well, certainly at the bottom, we want to talk about whether it can help individuals live longer. Some treatments do, some treatments don't. Some treatments will also, or in addition, instead of lengthening life, they can certainly help us live life with more function, with less side effects. And so we can get health benefits from treatments with or without the added benefit of a longer life. We do look at cost because value always in some way is going to be a cost for something. And we want to make sure that we're not just looking at the cost of the drug, because value really means how that cost ripples through the health of patients and their families and through the healthcare system. So might it prevent the need for hospitalization or new doctor visits? It can have cost offsets as well as costing something at the front end. So we look at all that, and then we also in the blue boxes want to be very aware that there can be things that are either hard or maybe even impossible to quantify, but that we still think of as important elements of value. And we'll talk about what we now call benefits beyond health. These can be spillover effects for patients outside of their health and how they work or interact with society. It can be the same for their caregivers. And there are other ways that a new treatment might provide benefits that are not directly captured by clinical trials or a cost-effectiveness model. And then in some sense, it can be put anywhere in this lineup or in some kind of enveloping role. We may have certain views around our ethical priorities here. Do we have a special social responsibility to think about this treatment because of the severity of it, because of the way it affects different parts of our society, either on a race and ethnic basis or on a rural kind of a geographic basis? Do we have ethical or social priorities that we need to bring in and be explicit about how we want to think about their effect on what we believe about the value of a treatment? So each of these has sections in our report kind of structurally set out that way so that we can talk about them in a very concrete manner, and they will be very visible as we go through the evidence today and then move towards deliberation, voting, and policy discussions. And that's the agenda. The agenda will start with a presentation of the clinical evidence review and then the results of the economic model that looks at cost effectiveness. We have our patient experts and our clinical experts available for all of that discussion this morning. We will then have public comments and discussion at approximately 10:40. These are Pacific time. We'll have a lunch break following by which we will return for further deliberation on these issues and specific votes by the CTAF panel. Then one more break before we enter a policy roundtable discussion where we'll really look forward and talk again about how do we apply the evidence as we know it today to what needs to happen next? How do we apply any kind of framework around pricing to what's going to happen next or should happen next? What lessons can be learned? What are still going to be the barriers that might get in the way of adequate access and sustainable pricing? How do we work around those and make sure that we have a platform for success going forward? So we will be done by 3 p.m. Pacific time with final comments from our policy roundtable members and the members of the CTAF panel itself. So with that, again, welcome, and I'm going to hand it back over to Ralph Brindis to chair the discussion, but I'll introduce Dr. Grace Lynn, who will present the results of the comparative clinical effectiveness research. Grace?
Thank you, Steve. Hello, everyone. I'm Grace Lynn. I am the Medical Director for Health Technology Assessment at ICER, and I'm also a Professor of Medicine and Health Policy at the University of California, San Francisco. Next slide, please. The report and this presentation is a collaboration between myself and the outstanding research staff at ICER, Shahryar Mohammed Fahim, Belen Hurs Hagawara, and Finn Raymond. Those are our disclosures. Next slide, please. So as you heard from Steve, metachromatic leukodystrophy, or MLD, is a rare disease, and many of us are probably not familiar with this. It's autosomal recessive it's an autosomal recessive genetic disease, and because it's rare, prevalence estimates are difficult. The disease is thought to affect anywhere from between 1 in 40,000 to 1 in 160,000 people, which translates to about 2,500 people in the United States. The disease is more common in such subpopulations as the U.S. Western Navajos, Alaska Natives, and Habonite Jew populations. MLD is caused mainly by mutations in the ICER gene, which codes for the enzyme aryl sulfatase A. What does the enzyme ICER do? Next slide, please. So here we see this schematic, and we see that aryl A, or the ICER enzyme, breaks down a compound called sulfatides, which are fats that are part of the building blocks for myelin sheath in the Schwann cells. And these are the cells that envelop neurons and protect them. If there's a deficiency of the ICER enzyme due to a genetic mutation, there can be an excess of sulfatides, and this excess of sulfatides actually disrupts the myelin production. As a result, the signals from the brain can't pass to the other parts of the body, and this causes some of the symptoms that you see with MLD. Next slide, please. The demyelination that results from MLD affects the central nervous system, resulting in a loss of cognitive and motor skills. Children with MLD lose the ability to walk, to speak, and to swallow over the course of the disease. And also at the severe stages of the disease, they have very poor muscle control where they can't hold up their head or breathe on their own. The demyelination also affects their peripheral nervous system, and so children lose sensation and the ability to sense touch and pain, heat and sound, and they can also have emotional and behavioral problems. The excess of sulfatides also can build up in organs and can cause a loss of bladder and bowel function and gallbladder problems most commonly. Next slide, please. So there are different subtypes of MLD, and this will become important as we talk about the clinical evidence. There's a late infantile form where the age of onset is between 6 and 30 months of age. This is the most common form and presents with developmental delays. So children start out developing normally, but then start missing milestones. And affects, this is about 50 to 60% of the patients with MLD. There is an early juvenile form with the age of onset being approximately 30 months to less than 7 years. And this can present with impaired school performance, cognitive and physical decline, and there's a slightly slower progression than the late infantile form. The late juvenile form, the onset is between 7 and 16 years, and there's an adult form, which the onset is after 16 years. I will not talk much about these forms of MLD because they're not the focus of our review. Just to note, there is a correlation between a child's genotype and their phenotype, and siblings do tend to have a similar disease course. So if you have a sibling who is diagnosed at late infantile, then any other siblings, within a few months have a similar time course. Next slide, please. What does having MLD look like? This is a slide that I borrowed from our clinical expert, Dr. Fumagalli, about the natural history of MLD. And here we can see MLD is split into different phases. Down at the bottom here, you see pre-symptomatic, early symptomatic, and symptomatic. So in the pre-symptomatic phase, children are developing normally. They're meeting their milestones. They look like all other children. At some point in the disease, children begin what's called the plateau phase, where demyelination is starting to occur from the sulfatide accumulation. In clinical trials, this is called the early symptomatic phase. start to develop milestones or they have declined motor function and regress, they enter a rapidly progressive phase where they can decline rapidly and finally end up with severe neurologic disability and eventually death. And this is the symptomatic phase of the disease. Next slide, please. In terms of current treatments, the main current treatment is supportive care, and this includes physical and occupational therapy, nutrition support, particularly as children lose the ability to swallow. They may need a gastrostomy tube for tube feedings. They will need wheelchairs and other assistive devices, symptomatic care, particularly helping them with cough and breathing, and eventually some children may be on a ventilator. One of the goals of treatment of MLD would be to slow disease progression. And right now, treatments to slow disease progression are few. Some children may be eligible for hematopoietic stem cell transplant. This isn't considered effective for the late infantile form of MLD, the really early onset, because that form is so rapidly progressive. It's only really considered for juvenile and adult forms of the disease. Stem cell therapy also needs to be done at the pre-symptomatic or early symptomatic stage to be effective, and because it can't reverse any already existing damage. There's also a chance that stem cell therapy could trigger more rapid disease progression and a risk of graft versus host disease. So for these reasons, it's not really considered it's considered a treatment option only in selected cases. Next slide, please. We appreciate the time that patients gave for discussions with us during this report. And they gave us some tremendous insight into the disease. As you can imagine, there is a very large impact on caregivers and the family. Caregivers in particular feel really unprepared for the level of care that children need at home. And one of the parents described it as the children needing basically ICU level care 24 hours a day and 7 days a week, especially in the later stages of the disease. Unaffected children, since this disease is autosomal recessive, there may be unaffected children as well, and they can be affected. There's always one parent who's always missing events. It's difficult to travel as a family given the limitations of affected children. And we heard that, because of the high caregiver stress, interpersonal relationships can be challenging and end in separation or divorce. There's also a tremendous financial impact. One or both parents often need to leave the workforce to care for their child or children. And we heard a lot about, and you'll hear later today, about the insurance barriers and the lack of coverage for things like 24-hour nursing care, special diets, home modifications, things like that are necessary for support of care for the child. We also heard a lot about the importance of newborn screening with the possibility of gene therapy that is most effective before the symptoms of disease appear. This is going to become increasingly important. Next slide, please. So here I'm going to dive into the clinical evidence. Next slide. So for this review, we are going to look at children with pre-symptomatic late infantile MLD, pre-symptomatic early juvenile MLD, and early symptomatic early juvenile MLD. And for the early symptomatic children, this is defined as the ability to ambulate independently and have preserved cognitive function. Next slide, please. The intervention that we are looking at is adadarcigine autotemcel, or I will be calling it arcicel during my remarks. It's been approved in the EU under the brand name Libmeldy, and you may also hear it referred to as OTL-200, which is its generic name. And we are going to compare arcicel with a natural history cohort. Treatment with arcicel is a process. It includes harvesting of a patient's stem cells. The CD34 cells are then transduced with a lentiviral vector encoding ARSA DNA. While that's happening, the patient undergoes bone marrow suppression with chemotherapy called busulfan. And then after the bone marrow, their own bone marrow is suppressed, these transduced cells are given back to the patient through an autologous stem cell transplantation process. Next slide, please. The key studies for our review, there's a phase 1/2 study, which was of 20 children with the pre-symptomatic late infantile or early juvenile MLD and the early symptomatic early juvenile MLD. And this looked at overall survival, measures of motor function, including the gross motor function measure and the gross motor function classification for MLD. And then cognitive function and ARSA activity. There were 10 patients enrolled in a phase 2 study using cryopreserved cells. The population was the same, and the outcomes were the same as the phase 1/2 study. And then there were 9 children treated under expanded access frameworks or compassionate use programs, all of whom met similar criteria to the phase 1 and phase 1/2 studies. Next slide, please. In terms of baseline characteristics, so we looked at 35 children treated with ARSA-cel, 18 in the late infantile phase 8 pre-symptomatic early juvenile, and 9 early symptomatic early juvenile. And you can see here that they had a median follow-up between 3 and 8 years. And 3 and yes, 8 years. And their age at gene therapy was fairly early in life. So for the pre-symptomatic late infantile, that was about 10 months. For the pre-symptomatic early juvenile, they had gene therapy at 16 months, and the early symptomatic early juvenile around 66 months. In the natural history cohort, you can see that there were 43 natural history children in the natural history cohort in Italy. And they were identified because they're mostly identified at symptomatic stages a bit later than the children who were treated with ARSA-cel. Their baseline GFM-FM 88 scores, which is a measure of motor function, were all age appropriate in the ARSA-cel groups. Next slide, please. So this is a slide of overall survival, and I'm going to talk first about the pre-symptomatic patients. In each graph, the x-axis is chronological age. On the left side are late infantile patients, the blue line are treated patients, and the green line represent the natural history cohort. You can see that while the numbers are small, especially as you get out to the right and children get older, no children in the late infantile group who were treated with ARSA-cel died, while as you get out here into older ages, substantial number of late infantile untreated children in the natural history cohort had died by last follow-up. Similarly, in the early juvenile, which is the right panel, the pre-symptomatic early juvenile patients, in this group there was 1 death, but otherwise everyone else survived to at last follow-up. And then the green line with the natural history cohort, you can see in the later ages that the children are to start to die, although at a slower rate than the late infantile patients. Next slide, please. This slide is the overall survival for early symptomatic early juvenile patients, and at last follow-up, all the patients in this cohort were alive, and you can see again that in the natural history cohort, the children are starting to die at the ages at last follow-up. Next slide, please. Here we have a table of the results for gross motor function measure. This measures children's ability to walk, skip, jump, rolling over, things like that. And these are results at year 2 of follow-up. In the ARSA-cel treated group, we can see in this red box that children in the late infantile, early juvenile, pre-symptomatic groups all have very high scores. This ranges from 0 to 100, with 100 being the highest score and higher scores being better performance. And you can see in comparison to natural history, their performance is in the single digits for the late infantile, and in the, like half the score for the early juvenile. By year 5, you can see that the treated group in the pre-symptomatic, late infantile, and pre-symptomatic early juvenile all, again, have preserved motor function, while the natural history group continues to decline and have very poor function. In the early symptomatic, early juvenile group here on the very right side of this table, you can see at year 2, the Arsa-cel treated group also has very high function. By year 5, compared to the natural history cohort, by year 5, that drops, the function drops a little bit, but it's still substantially higher than the natural history cohort. Next slide, please. In terms of ARSA activity levels, ARSA activity levels increased in all groups to normal or supernormal levels after treatment with Arsa-cel, and none of the treated patients had ARSA activity levels in their peripheral blood cells, where it's measured, below the reference range after up to 11 years of follow-up. So they maintained ARSA activity levels up to that last follow-up time. Next slide, please. In terms of cognitive function was preserved in almost all treated patients compared to the severe cognitive decline that was observed in patients in the natural history cohort. The majority of patients treated in the pre-symptomatic stages of late infantile and early juvenile MLD also remained in this GMFC MLD stage of 0 to 2. And this is another measure of motor function, and GFFC stages 0 to 2 basically are children who have the ability to walk. So most of the patients, treated patients, maintain that ability, whereas natural history patients had progressed to later stages. None of the trials collected any data on health-related quality of life, so we don't have any data to report there. Next slide, please. In terms of harms, all patients had grade 3 or 4 adverse events, mainly from the busulfan chemotherapy. And the most common adverse events were febrile neutropenia and stomatitis. Of the patients who had 7.5 years of follow-up, there was 1 death-related, and half of the patients had some gait disturbance, and 1/3 had motor dysfunction related to MLD progression. This was called a harm in the clinical trial, and some patients developed anti-ARSA antibodies. Next slide, please. In terms of controversies and uncertainties, these were small single-arm studies compared to a natural history cohort. We only have data up to 11 years, and since these children were transplanted at a very early age, on the order of months of their life, there are unknown long-term durability and long-term harms. There's a chance of disease progression after treatment. This was mentioned by several clinical experts that the busulfan conditioning regimen may hasten disease progression, and thus children can stabilize at a worse state post-transplant than pre-transplant. Parents also told us that they had this concern when considering gene therapy. In addition, there were 2 additional deaths in the early symptomatic, early juvenile patients in the early stages of the clinical trial that were excluded from the analytic cohort because they did not meet the current inclusion criteria of needing normal motor function and preserved cognitive function. Next slide, please. There's some potential other benefits and contextual considerations. We currently have no effective disease-modifying treatments in children with early onset MLD. Children typically die during childhood, so an effective treatment would have a dramatic impact. As I mentioned, caregiving impact is very high, and an effective treatment could change the healthcare infrastructure in terms of earlier and better recognition of the disease. Next slide, please. We appreciate the public comments we received on the report. One particular comment I wanted to flag is that patient groups told us that in addition to the direct harms of Arsa-cel treatment, they felt that not having access to an effective therapy like Arsa-cel should also be considered a harm, because by not having access to the treatment, they and their families lose the possibility of their children living a more normal life. Next slide, please. So in terms of evidence ratings, after considering the evidence I just presented, we felt that for children with pre-symptomatic disease, both late infantile and early juvenile MLD, there's a high probability of substantial net benefit from treatment, leading us to give these two subgroups an A evidence rating. For the early symptomatic early juvenile population, the results are less robust, and while these children appear to get benefit from treatment, these benefits appear to be smaller than those in the pre-symptomatic group. So we have moderate benefit of at least a small health net, moderate certainty of a small health net benefit. Excuse me. Thus, we rated Arsa-cel as a B+. Next slide, please. So in summary, early onset MLD is rare, but devastating. Excuse me. Treatment for pre-symptomatic and early juvenile MLD presents onset or delays progression of disease and extends survival. And benefit of treatment in early symptomatic is smaller and less certain. Children do not recover function previously lost, and there may be more rapid progression prior to stabilization. And of course, the question remains regarding the durability and long-term harms of Arsa-cel. So I'll finish there. I appreciate your attention, and I will be happy to take questions.
Well, thank you very much, Dr. Lin, for a very concise but thorough analysis on the presentation of the clinical evidence. And so we have an opportunity for our CTAF panel to ask questions to Grace, or she can refer them on to our clinical experts. And I would ask our panelists who are interested in questions to please raise their hand, and so that I can hopefully properly identify them. I see Rita Redberg. Rita, you're on.
Thanks. Thanks so much to everyone for this presentations and sharing your stories. Grace, I wanted to ask, you had mentioned prenatal screening. No, you mentioned actually early diagnosis, I think screening, and I was wondering if you would comment on what the current state is and what the hope is. And then my other question was on why those two tests were excluded. I did not follow the reason in the early juvenile MLD group.
Yeah, thanks, Rita. Let me answer that question first. So there were early on in the clinical trial, there were two patients treated, early symptomatic, early juvenile patients who had more symptoms, and in terms of they had lower cognitive measures. They were more cognitively had more cognitively progressed more and progressed with motor symptoms more than the current indication that I said earlier on in my slide presentation of having preserved motor function and normal cognition. And so they were excluded from the analysis because they would not be treated currently. You know, if they presented now, they would not be treated. So those are the two early symptomatic. Yes. It is post.
I mean, you already have the limitation of not being a randomized study, which I understand, but obviously the natural history group, I assume, was progressing.
Yes.
And they were diagnosed later, so.
Yes. In terms of, in terms of your earlier question, please, I'm sorry, remind me your earlier question.
It was about the current state of screening and the hope for state of screening.
Yes. So for the newborn screening, there is a test that's been developed for newborn screening. It's been piloted in Germany, I believe, and I think it's been piloted. It maybe have been piloted in a couple of states in the United States, but it is not because newborn screening has to be added state by state. It has not been added to state panels as of yet. So there is a newborn screening test available, which I understand is quite accurate, but it has not been implemented yet. And I know some of our patient groups have been, I see your hand, Taryn, you've been very involved in this, so I will let you also add comments.
Thanks so much.
Yeah, I wanted to say there is work currently going on to put a nomination before the RUSP nomination in before the federal committee. That hopes to be done early next year. We need FDA approval prior to being able to submit that application, but it is being worked on, and it is hopefully going to be done soon. Also, it is being piloted in New York in their Screen Plus, and it's soon to start in Tennessee as well. And Illinois has actually passed a law that it will be starting newborn screening in Illinois as well. So we will be getting more data from the U.S. Over in Germany, it is active, and they have already identified 3, almost I think 4 now, babies through the newborn screening process, and 2 of them for sure are going into treatment. So it's in the process, and hopefully it'll mesh with approval of the FDA approval here in the U.S.
Taryn, thank you very much for that new information for us. Jason.
Thank you, Dr. Lin and the research team, for an incredible report and an incredible job, so rigorous and so detailed and so much appreciated. I wanted to ask a question. This is sort of related to Dr. Redberg's point about this is just at a very high degree of evidence. And I get that the KM curves are shockingly different, right? There's a huge effect that we're seeing in this. But just maybe to comment on 2 things, one of which is to reserve this very highest rating for something without a randomized trial. You know, I understand that this very large. This determination is largely contextual. Like it really determines on were there selection effects in the way that the natural history cohort was constructed and the children chosen for the single arm trial, but just how that played into your deliberations about especially not only saying it works, but like the strength of evidence. And then I also had questions if any of the patients, this is related to this, in the natural history cohort received, it sounds like some patients had stem cell transplants in the absence of gene editing, whether some people got that in the natural history cohort. I entirely am humble and realize that it's incredibly difficult to conduct research in this space where there's a devastatingly difficult disease affecting children. So I'm not saying that they should have done randomization or anything like that, but I just wanted to see how that reflected your deliberation around the degree of evidence.
Yes, thanks for the question. So, I think a couple things we considered. One is that there is a pretty, especially in the early onset forms of the disease, and I think it's important to separate the early onset, the late infantile and early juvenile that we looked at versus the later forms of the disease. There's a very consistent, that we heard from the clinical experts and from what we saw from the natural history cohorts, there's a very consistent disease progression and disease course. So, these children progress very quickly and end up, with a lot of neurological devastation and die very early. And so we felt like, when we saw these results, while we had the same questions that you did about this is single arm and is the natural history cohort really, comparable, the disease course is fairly consistent. So we didn't think there was a lot of bias in the natural history cohort. There was also siblings in the study there, and I didn't talk about this, but there are pairs of siblings, and siblings have a pretty consistent disease course between siblings. And the treated siblings and the untreated siblings, you saw the same level of difference in terms of the treated siblings, had fairly preserved motor and cognitive function, and the untreated siblings had a natural history progression similar to what you saw in the natural history cohort. In terms of whether the natural history cohort, what kind of treatment they had, I will actually defer that question to Dr. Fumagalli, who was very involved in selecting the natural history cohort.
Thank you for your question. Great presentation of the data. In the natural history study, that is a retrospective and prospective study done at the same center with the same tools of the clinical trials, there are no patient except one having received hematopoietic stem cell transplant from donor. There is only one subject who received allogenic transplant in a pre-symptomatic phase, but the transplant failed in 6 months. So like receiving anything. So we decided to include this subject in the natural history because he was like he have never done the transplant yet, because he has 0 chimerism, donor chimerism in 6 months from the transplant.
I'll add one more thing about the evidence level here, answering sort of both the questions that just came up. I do think in the early symptomatic, early juvenile, where Rita was asking about the 2 deaths, we don't have a ton of patients. The benefit is not as great, and having 2 patients who died excluded sort of post hoc adds some level of uncertainty beyond where you'd be if people had excluded that before they started gathering. There's always the risk that, looking at the data later, you said, oh, well, these type of patients shouldn't be in there. And I do think that adds some uncertainty. We had some debates about whether the right evidence rating for that was B+ or not. There's clearly still benefit, but the amount of fuzz in that benefit feels larger for a number of reasons, and that's one of them, methodologically. Whereas, when you look at what happened in the pre-symptomatic patients, there isn't that fuzz. I mean, it's very obvious that you have enormous benefits. In the pre-symptomatic patients, I think it's still pretty clear you have at least some benefits in the early symptomatic patients, but we had debates about that.
Thanks, David. I see a number of panelists with questions. We're going to be short on time, so I'll ask that the questions be brief. Dr. Lowe.
Thanks. I'll be as quick as I can. I want to make sure I'm not bringing my own assumptions into this. Can you give me some understanding of the anti-ARSA antibodies? I see it's only 15%, but is that something I should be worried about as far as long-term durability? I'll leave it to you I'll stop asking there. How should I think about it?
Dr. Orchard, Dr. Fumagalli, do you want to take that question?
Well, I just mentioned this, Paul Orchard. I just mentioned quickly, we've done 4 patients with compassionate use. We haven't seen any ARSA antibodies in those patients. And Dr. Fumagalli can talk about the patients in Italy, but it's my understanding that all those antibodies essentially resolved. So, but she can expand on that.
Yes, I just can add that the patient who developed antibodies were 6 subjects. 5 of them have the event resolved. The antibodies occurs in the first months after treatment with very low titer and disappearing a few months later. And with the investigation we performed, we did not see any impact on clinical outcome or level of RCA activities or engraftment of corrected cells in this patient. No difference compared to the other subjects without antibodies.
Excellent question. Thank you so much. Bob Kyer.
Pardon me. Thanks, Ralph. I have a quick question that just kind of sticks in my craw here with the baseline characteristics slide, where we're talking about, we have an incredibly small N, of course, that we're all like really perturbed with. It's life that we have to deal with, and that's a real thing. But I'm curious that there's a line for male, and the overall natural history group appears to be relatively even, if not slightly female. And the treated arm seems to be largely male in several cases. Is there a reason for that? Is there some bias to the disease or choosing something? This is curious to me.
I see, Dr. McGuire, I see you shaking your head. Did you want to add any comment?
Being autosomal recessive, there is no reason to have more male than female, or having selected more in natural history respect to the trials. I think it's just by chance. It's very rare disorder, and probably increasing the number of treated patients, we would see same frequency. There is no reason to think that there is a differences or bias in that sense.
Thank you for that question. Dr. Hotch.
Thank you. Dr. Lin, thank you so much for your presentation and for always making the evidence so much clearer to us. I had a question for you about the survival curve for the group that is pre-symptomatic, early juvenile overall survival. I think it was in your slides. I don't remember which slide it was. It's in our evidence package as figure 3. And sometimes they're not fond of us screen sharing, so hand gesturing. But I think for this group, the evidence gets an A. But if I'm looking at the right curve, we may have already discussed this, it seems like the green curve, which is the natural history, are people who are doing better than the blue curve, which is the new product. And that doesn't change until the very end, where we have like almost no one in the analysis. And I wanted to understand, did I understand it right? And if so, why did you feel that this was evidence of worthy of an A?
Thanks for that question. Yeah. So, thank you, Steve. So this is, this is, you're talking about this right-hand panel here, the early juvenile. And so there was one death in so the reason that this blue line, which is the treated patients, is, seems like that there's, it's lower than the green line, which is the natural history at the beginning, is because the death that occurred in that group occurred at day 415 after transplant, so pretty early on. Nobody else in that cohort died. The early juvenile progresses a little bit more slowly than late infantile, and so that's why you're seeing, once you don't start to see that drop off like you do in late infantile until later on. As people are a little bit older. So we just don't have the data. So your question being, why did we feel like this was sufficient evidence? The supporting evidence is, and let's see, Yasmin, can you pull up sorry, Steve, if you stop sharing, can you pull up the supplemental slides, that slide number 5?
And Grace, while she's doing that, you said nobody else in that cohort died, but two more people died and were excluded post hoc, yes, which really would have dipped that curve well below natural history.
Yes, that's correct. So that
wait. Sorry, this is the pre-symptomatic group. They didn't.
No, I think that was the. Oh, okay.
No, you're looking at the pre-symptomatic survival.
Okay.
They did not get
that was okay. I'm sorry.
Yes, sorry. Thank you, David. So in this, we see the highest level of motor function at last follow-up, and this is GFMC stages 0 to 2, which is preserved function, and then all the way through 5 to 6, which is severe motor function, which is you can't walk, you can barely hold your head up, if at all, and then death. And you can see even in this pre-symptomatic ARSA-cell treated group that 7 out of the 8 were in GFMC 0 to 2, so they had preserved motor function. And then in and of course these are small numbers, but you can see that the people in the natural history group had all progressed. Between this, the level of ARSA enzyme that we saw in these groups, these were supporting evidence that even though the survival curves, we just didn't have enough time probably to see the survival curves diverge, that the children in the pre-symptomatic early juvenile group were getting pretty substantial benefit from the treatment. Hopefully that answered the question.
Really helpful. Thank you. Yes.
Thank you very much. And Dr. Lee, I apologize, but hopefully we can get to your question later. In the interest of time, since we're running late, I want to make sure that we have adequate time for now the presentation of the evidence and economic modeling. And I'd like now to introduce Dr. Kangwoo Soo.
Hi, thank you for the introduction. My name is Kang-Ho Soo. I'm an assistant professor from University of Pittsburgh. Next slide, please. I would like to thank several key members before I start, Doctors Josh Carlson and Ronald Dickerson from University of Washington School of Pharmacy, and Dr. Marina Richardson, Senior Health Economist at ICER. Financial support was provided to the Universities of Washington and Pittsburgh, but Dr. Carlson and I have no personal conflicts to disclose. Next slide, please. So the objective of this economic evaluation was to estimate the lifetime cost effectiveness of Arcicel. Next slide, please. Next slide, please. Here are the methods that we used for this cost effectiveness modeling portion. These are fairly standard ICER methods. We used a Markov model. In this case, because Arcicel met the ICER criteria to include as the healthcare sector and modified societal perspective, we used both in the base case. We used a lifetime time horizon and a cycle length of 1 month. The primary outcomes that we assessed were cost per quality adjusted life year gained, cost per life year gained, and cost per equal value life years gained. Next slide, please. Here's the model schematic that we used. We had a total of 8 health states, 7 related to the GMFC MLD that Dr. Lin mentioned in her presentation, where there are states from 0 to 6, and with each higher state, patients get progressively worse. And then the final state was a death state, and patients could only transition to the death state from GMFC MLD state 6. Some other things to note are that patients could only move sequentially to the next higher health state, so from 0 to 1, 1 to 2, and so forth. They could not make non-sequential jumps, such as from 0 to 2. For the early juvenile MLD population, there was a cognitive component that is detailed in the evidence report. Next slide, please. So for our model, the target population was a blended average of the 3 subtypes of MLD, pre-symptomatic, late infantile MLD, and pre-symptomatic and early symptomatic, early juvenile MLD. Next slide, please. These are the usual care, these are the mean times to transition for the usual care arm that we used in the model. And these are the numbers in the table are shown in months. So as the key take point here, so again, this is for the pre-symptomatic late infantile subtype. The other 2 subtypes are detailed in the evidence report. I think the take-home message here is that in the usual care arm without treatment, patients progress very rapidly, 3 to 4 months in the early and intermediary states of MLD. Next slide, please. For the Arcicel transition probabilities in the model, the treatment effect was based on several things. First was the response type, where we assumed that there would be 3 types of responders based on trial data. First was full responders, then stable partial response, and unstable partial responders. So if we look at the figure to the right, the stylized example, full responders are depicted by the blue line, where patients, after receiving Arcicel, quickly transition to a period of disease stabilization, which we assume to be 12 years based on trial data. And then after the 12 years, patients transition at a small percentage, 0.02% per month, to the unstable partial response group. Stable partial responders are depicted by the orange line, where there's an initial period of worsening. Before, in our case, we assumed a period of 1 year of initial worsening before they reach the period of stabilization for 12 years. And they also follow a similar post-stabilization disease progression of about 0.02% per month. The gray line is depicts the unstable partial responders, where they have a constant rate of progression, but slower than that of usual care. The post-stabilization disease progression that we used of 0.02% per month is based on prior ICER gene therapy reports. And this leads to about 9.2% of full or partial responders experiencing disease progression by age 50 in the pre-symptomatic late infantile subtype. Next slide, please. Some additional model assumptions that we made are that patients can only become progressively worse, so they can only move to a higher GMFC MLD state. As previously mentioned, patients can only die from health state 6. And we implemented a 1.4% risk of death from infusion work for gene therapy in the first model cycle. And this was, again, based on prior ICER reports in gene therapy. Next slide, please. This slide shows the treatment costs that we used for Arcicel. So we assumed a one-time cost of Arcicel of $2.8 million. This was a placeholder price that we used based on a prior health technology assessment of Arcicel in a European country. We also implemented a one-time Arcicel administration cost of about $170,000, which includes costs such as cell harvesting, conditioning, and follow-up costs that Dr. Lin also mentioned in her presentation. Next slide, please. Here are the healthcare sector costs, monthly costs that we used in our model. As you would expect, and as you can see, as patients progressively get worse from 0 to 6, the costs increase very rapidly. And so because these are monthly costs for GMFC MLD state 6, if a patient stays in that health state for a year, the cost would be $240,000. And in these later states of a GMFC MLD, the costs are due to things such as hospitalizations, nursing care, and healthcare equipment. Next slide, please. These are the indirect monthly costs that we used in the modified societal perspective. And these estimates came from survey responses from US caregivers of MLD. Next slide, please. These are the health state utilities that we used in the model. Here we just show the late infantile utilities. The early juvenile utilities that we used are detailed in the evidence report. Key take point message here is that the utilities get fairly worse fairly rapidly, as you would expect, and they even reach the negative space, underscoring the severity of the disease, and these negative utilities can be interpreted as states worse than death. Next slide, please. Here are the caregiver disutilities that we used in the modified societal perspective. And so disutilities are essentially quality of life decrements of a person's normal quality of life. And similar to what we saw before, the disutilities get larger and get worse fairly rapidly as patients progress. And just to provide some context of the negative 1.89 in GMFC MLD stage 6, that negative 0.19 is similar to the disutility that we would see in patients with senility-related cognitive changes. Next slide, please. Now I'll go over the results. These are the base case results. Two things to note before I detail some of the results. These results are, again, based on the placeholder price of about 2.8 million. And these results here are a weighted average of the proportions of the 3 subtypes. So treatment with Arcicel compared to usual care resulted in an increased total cost of about 2.4 million over the lifetime of a patient's, over the lifetime of the model. Along with this higher cost were gains in quality of life years of about 19, EVLYs of about 21, and life years of about 18. In the modified societal perspective, we saw similar results. Next slide, please. These are the incremental results for the base case. Again, these are based on the placeholder price of about 2.8 million and again, a blended average of the 3 different subtypes. So for Arcicel compared to usual care, we saw an incremental cost effectiveness ratio of about $127,000 per quality gained, $111,000 per cost per EVLY gained, and about $131,000 for cost per life years gained. And we again saw similar results for the modified societal perspective. Next slide, please. So because of the base case results were a blended average, we also show here the subtype specific incremental results using a placeholder price of about 2.8 million. Here we're highlighting the pre-symptomatic early juvenile subtype because in this subtype, the assumption was that 100% of patients would be full responders, and that's why the incremental cost effectiveness ratios you see here are quite a bit lower than the base case results and more favorable. Next slide, please. We ran various sensitivity analyses. The first one we did was a one-way sensitivity analysis. And so what we do here is we take one model input parameter at a time and we vary it at a low and high input. And then that way we can see which one parameter is most influential to the model. And so you can see going from top down, the placeholder price that we used for Arcicel was the most influential to the model. And then subsequent influential parameters were transition probabilities, as well as the health state costs that we used for health state 6. Next slide, please. We also ran a probabilistic sensitivity analysis. In this sensitivity analysis, we varied not one parameter at a time, but all parameters simultaneously, and we ran 1,000 simulations. And then the numbers here show what percentage of those 1,000 simulations were cost-effective at specific thresholds. So for the healthcare sector perspective for Arcicel, 97.2% of the simulations were shown to be cost-effective at $150,000 per quality gained. Next slide, please. We also ran various scenario analyses. All of them are detailed in the evidence report. Here, we just want to highlight 2 of them. The first one where we used rescaled utility estimates where we did not allow for negative utility values. The other scenario analysis that I want to highlight were where we used a different or an alternative caregiver disutility set. But in either case, our conclusion around the cost effectiveness of Arcicel did not change. Next slide, please. Here we show the health benefit price benchmarks that we found for Arcicel. Across different thresholds, 100,000 and 150,000, across the 2 different perspectives that we used, and across qualities gained and EVLYs gained, we found that the health benefit price benchmarks would be around 2.3 million to about 3.94 million. Next slide, please. So we did have a few limitations with our cost effectiveness model. As mentioned in the clinical evidence presentation, we were limited to model inputs from a small sample size from the clinical trials. The durability of treatment effect, which includes the disease stabilization period as well as what happens post-stabilization, that durability is unknown, but that was a limitation. And then there is uncertainty around the number of treatment response categories. And so we just wanted to highlight these limitations. Next slide, please. So as far as the comments received, we did receive some comments whether we should use a utility set that allows for negative values or rescaled non-negative values. We decided after consideration that we should use the negative value set for our base case. And then similarly, we received comments around the durability of treatment effects and what happens after the stabilization period ends in terms of progression. And after consideration, we changed our approach to what I outlined in this discussion. Next slide, please. So in conclusion, Arcicel provides clinical benefit in terms of gains in qualities, EVLYs, and life years over usual care from both the healthcare sector and modified societal perspectives. The eventual cost effectiveness of RSSL will depend on the actual price of RSSL, but at the currently assumed placeholder price, RSSL would be cost effective at a commonly accepted threshold of $150,000 per quality gained. Next slide, please. And thank you.
Well, thank you, Dr. Su, for an incredible presentation related to the economic modeling. And we have opportunities now from questions from the CTAF panel, and hopefully Dr. Lee will have time for your question that you had for in Grace. So Dr. Lowe?
Yeah, thank you. Great presentation. Lab costs are well outside my expertise. I'm wondering if there's any insight if we had considered a universal newborn screening. You know, it's very hard to detect a rare condition in a large population. Was there any consideration of modeling that as well?
Thank you for that question. So we did briefly talk about it, but we chose not to include that screening component because then that would reframe our interest, which was looking at the treatment of RSSL once patients are diagnosed with the disease.
Thanks. Stephen.
Excellent. Thanks for the terrific summary and really nice job on the modeling by the team. You know, kudos to everybody. Very straightforward and clear. I think one interesting thing about the model, and I'm glad you did a scenario analysis about not discounting future life years. I think the analysis also maybe speaks to maybe some of the debate around whether or not and when it's useful to maybe think about a scenario where we don't discount further life years because you see, you know, the impact over decades of life as it, I think it was one of the more favorable ICERs in your analysis was when future benefits were not discounted. But, you know, that aside, just one question I had about another modeling input that might have been considered, which was sequelae, long-term sequelae of myeloablation. So, you know, maybe some concern about a longer-term solid tumor development and maybe other long-term consequences. Perhaps incidence low enough where it wouldn't have that much of an impact on the model, but maybe even just to kind of put a stake in the ground to include that in the mix as well. So be interested in your thoughts on any of that. Appreciate it.
So I think thank you for those points. We did not consider that approach, but I guess it is something that we could consider if we did have evidence or data on those inputs. But yes.
I'm feeling like this is unfair to Kanho since that's of course coming from the clinical team, whether we included this or not. You know, this is the third or fourth lentiviral gene therapy requiring an autologous bone marrow transplant that we've looked at. And while we've worried about the consequences that you're talking about as low frequency events that could cause harm and harms that we don't think we know about yet because we haven't gone out far enough, we haven't tried to include them in the economic model. What we have done is included a risk of death, despite the fact that when we've looked at the actual studies, nobody has died of these transplants. But when we talk to experts, we expect there will be deaths. And those, of course, have a bigger effect on the model because they're happening right away, right at the beginning. And that, you know, that rate of death that we included has a small effect on the model, but it's going to have a bigger effect than a downstream development of, you know, a myelodysplastic syndrome or something.
Yeah, just no, we wouldn't expect those to have really meaningful impacts on the incremental results because they're low frequency and far, far in the future.
Thank you, David and Josh. Jeffrey.
Thank you. Thanks for presenting your hard work, trying to summarize the evidence into an economic model. Not the easiest thing to do. I remember you mentioning that there were other studies of cost effectiveness, and I wondered if you could share with us how does your model and its results differ from other studies of the cost effectiveness of this product?
Sure. So the only other cost effectiveness models in this space were developed by the manufacturer for other health technology assessments. And so while the incremental cost effectiveness ratios and total costs are redacted from those other health technology assessment reports, our life years and QALYs seen with or modeled with Arcicel were very similar. And so, that's the only outcome that we could compare. And I would say we were fairly consistent with the other prior models.
Were those prior studies giving estimates that were maybe a little bit higher or a little bit lower or about like the same?
I don't remember off the top of my head, but I think they were very, within, I don't want to put a percentage on it, but they were very similar.
Cool. Thank you.
Donald.
Thank you. I'm not sure if this is a question or a comment, but in the context of an analysis that arises out of or conducted without a specific price from the drug company, so relying on a kind of a hypothetical or assumed price, the MLD Foundation in its comments noted that Orchard Therapeutics and other gene therapy companies have been lobbying for the ability to provide contractual guarantees that basically say, you don't have to pay us unless our therapy succeeds. And the MLD Foundation said that should be reflected in the ICER model. And the answer that the MLD Foundation got back from ICER, I thought was a little cursory. It basically said, we're not going to do it. We're not in a position to do that. And I want to push back against that. I don't know if this is a question for Dr. Rind or whoever, but I'm just curious about why ICER, in this particular context, given the importance that the MLD Foundation seemed to attach to that possibility, ICER was so kind of dismissive of that idea.
Yeah, sure. Thanks, Don. What we do with our single and short-term therapy analysis is go to the company and say, would you like us to do a scenario where we include guarantees like that? Will you tell us what sort of analysis you'd like us to do, and we'll do one. And the manufacturer did not ask for one in this case. And so we've typically done them when the manufacturer will tell us what something like that looks like. And we didn't have that here, so we didn't model it. That's what happened.
Understood. Thank you.
Aaron?
So I'm remembering an anecdote from a colleague, hematologic oncologist a few years ago, and remarking about how as the prices of many cancer drugs have accelerated in recent decades, they has made the comment to put things in perspective. It's like, well, we've actually had, $1 million drug for quite some time now that we've been using for decades. It's called stem cell transplant, which is very expensive when you consider all of the follow-up care that goes into that. And so what I'm curious about is, this is maybe partially for ICER, partially for the clinical experts, is I know that our direct comparator is kind of usual care, but I wanted to clarify, did the usual care include the portion of patients, if known, that would go on to an allogeneic stem cell transplant and the costs associated with that? And if it didn't, which was my read of the model, does that happen commonly enough in clinical practice that if we were assuming a fairly durable benefit of Vericel for this patient population, that it's going to be to some extent displacing a separate expensive standard of care that could change the model conclusions?
Sure. So I could take a stab at it before having David or Grace respond, but I think based on our the scoping phase with clinical experts and so forth, the stem cell transplant was not part of usual care therapy, and so we did not include that as part of the cost for the usual care arm. I don't know if David or Grace, you want to jump in?
There was a fair amount of discussion about this up front. There's real debate about whether stem cell therapy for this group of patients works at all. And so you end up having a therapy that costs money and may not provide any benefit. And so comparing a treatment that works potentially to a treatment that doesn't work and just adds dollars didn't make sense. And the manufacturer didn't ask us to do that, which sometimes manufacturers do. And so we felt it was more fair not to include that. And I see Dr. Orchard has his hand up. I know that there is some disagreement, even among the clinical experts on this call, on this meeting, about what I just said.
Well, actually, I wasn't going to advocate that much for transplantation, but I think there's maybe three pieces to this. One was the cost that was initially discussed, and about $1 million cost is probably reasonable for transplantation. So, it's maybe less expensive than gene therapy, but it's not a cheap therapy. But in the other considerations for transplant, there's the safety considerations, and then there's the efficacy considerations. And from a safety standpoint, I generally would tell families that would consider transplantation that the mortality rate of transplant is about 15%. So nobody's died on this with this gene therapy in a peri-transplant, peri-infusion period. And as someone mentioned, I think that the risk of mortality is not zero. I think there's patients that as they're neutropenic, and all the patients on these getting busulfan at this kind of dose are going to get neutropenic, there's going to be some risk of infection, there's going to be some risk of thrombocytopenia and catastrophic bleed or whatever, but it's probably at least an order of magnitude safer, the gene therapy, as an allogeneic transplant, not to mention the comorbidities like graft versus host disease and other types of complications. So, and then the other big piece is the efficacy side. And as best we can tell, the amount of enzyme that's delivered is important in achieving the outcomes we want to achieve. And, transplantation maybe is improved in terms of safety over the last 20, 30 years that we've been treating these patients, but efficacy has not gotten any better. So if you've got a patient through transplant, they're fully grafted with donor-derived cells, we're not delivering any more enzyme now than we were back in the 80s when we started doing this. And there is the opportunity for increased enzyme delivery with gene therapy. So from our standpoint, at least from my standpoint, I can't speak for all transplanters everywhere, but I think there's clearly with gene therapy, the opportunity to have not only a safer therapy, but a more efficacious therapy. And so if both were available to offer, I wouldn't have any hesitations at this point in choosing the gene therapy.
Terrific comments, Dr. Orchard. Thank you so much. Bob?
Yeah, many of you may not be, others off of CTAF may not be aware, but we've done the most recent 2 drug treatments for Alzheimer's. The skew between this and Alzheimer's is just like really profound. And it's at either end of life. Then they both are in very real circumstances, very real senses, diseases of caregivers as much as patients. And in that regard, I just a bit of context there. I want to give a hearty pat on the back to a health economist now that put plain English into his presentation here, particularly with actually pointing out to people what disutility actually means. And trying to highlight within the presentation the actual, this is as close as we've come, I think, to actually spelling out for the patients the usual gripe about you're not including the actual cost in the real world for these families. And you've at least made a stab at that, and you've at least put it into plain English. And I would literally stand up in an in-person meeting and give you a hearty pat on the back for that. So thank you very much.
Thank you.
Thanks, Bob. If there are any other questions from the panelists, even back to Grace, we were running a little tight there. This would be the opportunity. We have a couple minutes. Seeing none, I again want to thank both Grace and Kanghu for their terrific presentations on the clinical evidence and economic modeling. And I also particularly want to acknowledge our CTAF panel for their insights and questions, and also the discussants related to them. I think we really have gotten a thorough feeling and understanding related to the treatment and the aspects of this particular disease. With that in mind, I think we're going to advance ourselves to the public